Hello, everyone. My name is Megha Prasad, and I'm here at AHA 2015 in Orlando. Today, we're joined by Dr. Dwight Reynolds, who's a professor of medicine and the chief of cardiology at the University of Oklahoma. He'll be talking to us a little about a transcatheter pacing system. Dr. Reynolds, could you tell us a little bit about this unique pacing system?
Yes, and thank you for this opportunity. Um, the device itself is a small capsule that is 2 cc's in volume. I'm sorry, 1 cc in volume and 2 grams in weight, and is designed to be positioned into the area of the apex of the right ventricle. It's a leadless device, requires delivery by a catheter that we employ from the femoral vein, and it's fixated in the right ventricle using some nitinol tines, flexible tines. It's been a vision for about 35 years to do something like this, but the ability to downsize because of improved battery chemistry and improved circuitry has just become a reality. We've implanted the device in the trial, a first-in-man trial, in 719 patients out of 725 attempts to implant. So that's a 99.2% success rate in implantation. Some of the highlights about it are that we've had no dislodgements and no systemic infections. The endpoints for the trial, the primary endpoints for the trial, have been a safety endpoint, primary safety endpoint, and a primary efficacy endpoint. The primary safety endpoint was designed around avoidance of major complications with the device at the 6-month mark following implantation, and the efficacy objective around low pacing thresholds at the 6 months, low and stable pacing thresholds. We hit the mark beautifully with a safety profile, freedom from major complications of 96%, and an efficacy endpoint satisfaction at 98.3%. So we're very happy with the results of the trial. We had a historical data set involving 2,667 patients. It's not a 2-arm trial. It was a single-arm trial, so we didn't have a parallel control. But we used this published set of 6 pacemaker studies to look at a comparator group. The micro group was a bit older and had significantly greater comorbidities than the traditional pacing system controls. I think it's important to point out that the major reasons for doing something like a non-lead-based system are that traditional pacing systems with leads have the problem of lead failures. Leads fail more than the devices themselves, more than the pacemakers themselves. So that's one big issue. The other issue is pacemaker pockets and the hematomas, and more importantly the infections that occur related to that. And then the third part of the raison d'etre for the device itself is the avoidance of having leads in the vascular system, in the venous system. So in patients that have end-stage renal disease, dialysis requiring, or cancer chemotherapy catheters, we don't mess up the veins with pacemakers with something like this. Also, we think, haven't really had an opportunity to assess this completely, but we think that patients that have problems with the tricuspid valve, or that have prosthetic tricuspid valves, may be served well by a leadless system.
This is all very exciting. How long do you think it'll be until we're able to see this in practice?
Well, that's a very good question. I will tell you that in Europe, the device is available it's commercially available. In the U.S., the FDA approval process is underway. We anticipate that sometime in the latter part of 2016, it's likely that the device will be approved, we hope. We think that's, and we think this is the beginning of an era of small non-lead-based devices. This one is specifically designed for use in the right ventricle. That enfranchises a significant number of patients that require pacemakers, but we also realize that there's a need for devices for atrial and even left ventricular application. So that's going to require some ongoing technology evolution.
Well, we'll look forward to hearing more about that. Thank you so much for joining us today, Dr. Reynolds.
Thank you.
For more videos like this, please go to www.youtube.com/fitsonthego.